talk, which is to be given by Professor Rajesh Sinha, who's
Thank you,
going to talk about not very common but very serious disease, infection of cornea with Acanthamoeba. And we know that Acanthamoeba keratitis can be very, very difficult to treat. And he'll highlight all the difficulties to be solved in this group of cases. Dr.
Thank you,
Rajesh Sinha.
Thank you, sir. And as Professor Titala said, that it's not a very common condition, not a very common keratitis. But many times what happens that people, in order to, when you have this concept that it's not very common, then you don't keep this in mind, and many times you miss it as well. So you have to keep it in mind, although it's less than 1% of all microbial keratitis. You have to clinch the diagnosis based on some risk factors as well. Somebody who's a contact lens user, who slept with contact lens, or who did swimming while using contact lens, and then coming with some symptoms, you have to suspect that it may be keratitis. Somebody who's using tap water for cleaning the contact lens. I mean, there was a study in UK on tap water, and they found out that 80% of the samples of tap water had some amoeba in it. So we can expect definitely that in our country as well. So all these factors can help you to think about Acanthamoeba keratitis as well. You have to keep it in mind. It is mostly unilateral, has severe pain in immunocompetent patients, but those who are immunocompromised, like HIV positive or established diabetic patients, they may have painless Acanthamoeba keratitis as well. And many times we diagnose, as I said, when it fails to respond to all the other antimicrobials. So as I said, the symptoms can be pain, redness, photophobia, and blurring of vision. And on examination, in the initial part, which very uncommonly you get, there can be epithelial irregularities or dendritiform lesions which can be seen. There can be patchy stromal infiltrates or the perineural infiltrates, but these are definitely pathognomonic, but these are not very often seen. The patient comes to you with something like ring infiltrate and severe infection. Something like this, when you examine the patient, you get a ring infiltrate. Ask the patient whether the patient is using contact lens. If he has used contact lens, this ring infiltrate can be because of two reasons. One can be Pseudomonas, the other one can be Acanthamoeba. If it is very rapid progressing, then it is Pseudomonas. If it's not rapid progressing, it is slow progressing, then it can be Acanthamoeba. So based on the initial history itself, you can somehow guess that what is it. And as I said, it's a slow progressing, doesn't have much vascularization, but if there is scleritis or limbitis, then you can have vascularization like this, or you can have scleral nodules, which can thin out with time. And this is one case wherein there was a fleeting type of scleral nodule that we saw, and throughout 360 degrees the patient had nodule, and then there was atrophy, and then again there was a nodule. So such a thing can happen, and based on history and based on examination, you can somehow guess that it may be Acanthamoeba. But yes, microbiological diagnosis is something which we should always do in all the ulcers. We do corneal scraping, we can do confocal microscopy, and by confocal you can get to see thickened nerves. You can get to see these, you can see here, the thickened nerves will be seen like this, and then as you move forward, you can see the double-walled cysts. And then as you move anteriorly, you get to see the refractile trophozoites in the basal epithelium of the cornea. And on staining with calchlorofluor white, and you can get to see this apple green fluorescence of the double-walled cysts. Trophozoites are difficult to stain. When you send the sample for culture, you send it in non-nutrient agar with live or killed gram-negative bacilli, and wherever the Acanthamoeba feeds on these E. coli, there is presence of depressions or trails, and on serial transfer, you actually confirm that it is Acanthamoeba and not macrophages, which can also cause pseudotrails. And PCR has been shown to be a very effective tool in diagnosing Acanthamoeba, apart from other investigations. As far as treatment is concerned, it is definitely a challenge because many times we don't get these definitive drugs. Bigonide is the treatment of choice, chlorhexidine or PHMB, 0.02%. PHMB normally is not available in the market, but there is a company that's called ARCH, which has which sells PHMB in a concentration of 20%, and that can be bought and that can be made 0.02%. Diamidines, again, not freely available, but if it's available, it can be used, and both the drugs can be used as a combination therapy, 1 hourly for 48 hours, and then of course, you can reduce depending upon the response. Systemic therapy with azoles are again useful in these cases. And a new drug that is miltefosine, which has been used in animal studies. And also there are a couple of reports, one with systemic miltefosine and one with topical, and they have shown good result, but these are just one of case. And maybe with time, this is that study that has been published in the American Journal of Oral Miltefosine for refractory Acanthamoeba keratitis, wherein miltefosine was given 50 milligram 3 times a day, but this is just one case, and we have to know more about it. As far as steroid is concerned, it is not routinely given, but if there is clearitis, in that case we can give steroid and under cover of bigonides. And sometimes the scleritis doesn't respond, so you have to give a long-term mycophenolate, which can be started 500 milligram twice a day, increased to 1.5 with time, and then later on you can stop it. Supportive therapy, as we all know, is very essential because these patients have a lot of pain, and many times the NSAIDs don't help. You have to resort to opioid drugs, and sometimes these patients do require lignocaine or amitriptyline patch as well. In a couple of patients, I have used them, and the patients have really benefited and had reduction in pain. CXL and PTK, there are a couple of just reports not yet established in this. And the last thing that people would like to do is that if it is not responding to any drug, then we have to do keratoplasty, lamellar, or penetrating. Lamellar, of course, if it's not involving the full thickness, and penetrating if it's full thickness. The key is that the risk of recurrence is high after keratoplasty, so we have to give medical management initially to some extent so that there is some limitation of the infective load, and then after that we can go ahead with any sort of keratoplasty. So thank you very much for your patient listening, and any suggestion, any question, if you...
Thank you, Rajesh, for highlighting the Acanthamoeba keratitis.